హలో శివ. హలో.
చెప్పు సౌమ్య.
ఒకసారి యూట్యూబ్ ఓపెన్ చేసి చెక్ చేయవా?
రావట్లేదు.
ఆ?
రావట్లేదు. ఓకే, వస్తుంది వస్తుంది వస్తుంది.
వస్తుందా? నేను
యా.
చూసుకొని చెప్పు, నాకు రావట్లేదు అన్నది కానీ మళ్ళీ నాకు.
హలో.
Hello, can you hear me?
యా మ్యామ్.
Okay,
హాయ్ మ్యామ్,
just give me
గుడ్ ఈవినింగ్ మ్యామ్.
good evening, good evening, good evening. Let me mute myself.
యా, ఇట్స్ ఓకే మ్యామ్. సో వీ కెన్ చెక్ లేటర్ మ్యామ్. కెన్ యూ ప్లీజ్ షేర్ యువర్ స్లైడ్స్ మ్యామ్?
This is today's class.
ఎస్ మ్యామ్. ఓకే. సో మ్యామ్, వీఆర్ ఇన్ లైవ్ మ్యామ్. కెన్ వి స్టార్ట్ ది క్లాస్ మ్యామ్?
Just give me 1 minute, please.
ఓకే మ్యామ్. సౌమ్య, ఒకసారి అన్ని చెక్ చేసుకో, ఇంకా ఓకే అనుకుంటే క్లాస్ స్టార్ట్ చేస్తాం.
Let's start.
No, no, ma'am. They will start, ma'am. So if everything okay, then we're gonna start.
My voice is not echoing, right? There's no technical issue that you have to edit my videos later on.
No, no, ma'am. Previously, like the videos didn't went for the YouTube, so that's why they are recording and they are posting again. So now this video is directly streaming on YouTube now.
My
యూట్యూబ్
camera is
యాజ్ వెల్
working. My
రికార్డ్,
voice
వి
is
ఆర్
not echoing.
రికార్డింగ్ ఆల్సో.
Yeah, okay. Let's start.
Okay, so నేను మ్యూట్ చేసుకుంటున్నాను. స్టార్ట్ చేసేసావా?
సరే, ఓకే ఓకే.
Tell me when to start.
మ్యామ్, యూ కెన్ స్టార్ట్ ద క్లాస్ మ్యామ్.
Hello, everyone. I'm Dr. Nawal and I'm Modi today. So today again, we'll have a class on disorders of middle ear. Today's ENT class will be disorders on middle ear. And before that, I just want you to have a brief introduction to our platform called Auricle, where we train students for their academic exams and also for their next exams. So we have a rapid revision for all important questions on this platform. We have quick revisions here. We have high yield topics that we cover for the students for all the subjects, not just ENT. And most expected topics, most repetitive topics that will come in exam, your university exam, your next exam, FMG exam, All those exams will be covered here. So today's questions will be long essay about mastocytosis, myostardectomy. In short, we have here on your screen tympanic membrane proliferation, tympanoplasty, and we have symposium, that is acute suppurative otitis media, serious otitis media, and government, along with petrositis. Now, why do you have to choose Auricle? We have 5 benefits on this platform where you can get recorded classes, we have live classes, we have practical sessions, we have exam modules, and also we have hard copy sets for anyone who wants or who cannot, who doesn't want to carry on with their textbooks. They can use these hard copy sets. Now, recorded classes, you will have flexible learning. You'll be taught with expert instructors who will record their classes with particular subject or topics, and you can come in to the application and you can rewind that video and you can see it conveniently according to your pace. On the other hand, we have live classes. So in live classes, we have educators and tutors who uses their 10-year previous question papers and make the class for you and explain you the questions and answers and everything. It is a depth coverage. We'll have a one-on-one question answer sessions, and it is an interactive learning, of course, because it's a live class. Of an express exam module, this is like a crash course where we complete the syllabus in 20 hours. This is only before the exams, okay? Where we will also give you hints and tricks and tips of how to write the answer in the exam hall. And these are done by expert educators in this specific field. We have one-to-one doubt clearing sessions in the essential topics for MBBS final exams, where we provide tips to the students with important points necessary that you should write in the exam. The key word that you should present in the exam, which will boost you with the marks, okay? So it is a student-centric approach. We have personalized attention to every student, and we have a safe learning environment here. Coming to the hard copy note set, these are notes that are made by experts in that particular field who have created notes in such a way that you will not have to use reader, your textbooks, but that doesn't mean that you betray the textbooks. But yes, this is more centric way of letting you know how you should learn, what is important, what can be let go, and how you should how you should prepare for yourself an exam before sitting in the exam hall. Now we have a question bank. It's an application. We have 3 levels here, beginner to expert level. It is a customizable question bank. If you download this application, you can download it in your mobile phones and in your tablets, all your devices. It covers MCQs for FMG examinations, for NEET PG examination, and also we are coming up with next examination as well. We also train students for practical sessions where we give them hands-on experience. We have expert guidance here by expert teachers who will teach you how to present yourself in the exam hall in front of the external examiner, and they will also help you to excel in this examination. We have a 4-year subscription plan. It's there on your screens. First two subscription plans, you do not have a benefit of hard copy sets or one-on-one doubt clearance set. But the last 2 that we have, complete learning plan and ultimate MBBS plan, that's for 4 years. You have benefits of all the sessions that we have in our platform. You can have a look at that. Also, you can use a QR code for discount, DR space WAL MOHAMMED 20. Let's begin our class. So today's disorders will be the disorders of middle ear. So disorders of middle ear, we have 4 important things, 4 important disorders that we all should know. Acute suppurative otitis media, acute necrotizing otitis media with effusion, and aero-otitis media. Now remember, if it is media, it is middle ear. Okay. And if it is an external, it's external ear. Of course, it makes sense, but most of them make mistakes here. So if it is acute suppurative otitis media, it means suppurative otitis media of the middle ear. If it is acute suppurative otitis externa, it is otitis of external ear. Now, otitis means inflammation, otic. Inflammation of the otic organ of the middle ear, okay? Acute suppurative otitis media, acute necrotizing otitis media with effusion, and aero-otitis media. Now, the last one that we have, aero-otitis media, it is also known as barotrauma. We have covered this topic in the previous class. You can go and you can look at the mechanism of action of barotrauma, like how does a barotrauma happen and what actually happens, how the pressure changes from the middle ear to the external ear, and what actually happens in the barotrauma, and how do you treat barotrauma, because it is an important 2-mark question or a 4-mark question. So it's not like we have not covered in this class. It's just we have covered it in the previous class. You can go back to the previous video and you can see in the aero-otitis media topic. So today we'll be covering the first 3 topics: acute suppurative otitis media, acute necrotizing otitis media, and otitis media with effusion. Coming to acute suppurative otitis media. First of all, I told you, in examination, all the students should be able to write the exam in this format of definition, right? Roots of infections, or if it is their risk factors or pathological factors, followed by clinical features. If the diagnoses are present, you should write the diagnosis. And then you should write the treatment. Diagnosis doesn't mean how did you diagnose or not diagnose the patient. It means diagnostic tools that you use. Okay. So now, definition of acute suppurative otitis media. It is an acute inflammation of the middle ear. Remember, it is an acute inflammation of the middle ear by organisms. Okay. Now, here what happens is that the middle ear employs to middle ear cleft. Here, what does it mean by that? Is the osteition tube, the middle ear, the attic, the additus, the antrum, and the mastoid air cells. Everything are involved. Okay. I'll write it down here that it is because of pyogenic organisms. What does middle ear actually mean here? Middle ear means middle ear cleft. So what comes under middle ear cleft? We have mastoid air cells. We have osteition tube. Right? We have attic, additus. And of course, the middle ear. Okay, these are the 4 components that make middle ear cleft. And the examiner will ask you what are the 4 components that implies for a middle ear cleft. You should be able to say that middle ear involves osteition tube, middle ear, attic, additus, antrum, and mastoid air cells. Okay, now there are 3 routes of infection. It is very important. Before that, we'll just know the etiology for your information. It is most commonly seen in infants. So acute suppurative otitis media is seen in infants, okay, and in children, especially school-going children. Now, one more thing is you should know that children who are of socio-economical status, whose socio-economical status are low, this is usually seen in those conditions, but we can just rule out this socio-economic part. Just remember that infants and children are usually infected with acute suppurative otitis media. It is usually after viral infection of upper respiratory tract, but soon the pyogenic organisms will invade the middle ear. So the child will have symptoms of viral infection. The parents will say, our child had flu, he might have flu, he's having flu. Some parents will also give them medications over the counter. Some parents will take them to the doctors and the doctors will be like, it's normal flu. After that, what happens is that the acute suppurative otitis media will set in. Okay. So now, after viral infection, there are 3 routes of infection. One is osteition tube, one is via external route, and one is blood-borne. Okay, blood-borne is usually an uncommon route. Okay, now what happens via an external ear is it means that the route of infection will be entering into the middle ear from the external canal. Now, it is because of the perforation of the tympanic membrane due to any cause of opening. Maybe the child might have ruptured his tympanic membrane. Maybe he had a foreign body inside his ear that might have ruptured his tympanic membrane. Maybe some sort of injury or an accident. Usually when the parents slap, that's the only case when we get a tympanic membrane rupture, parent abuse. That's only when we have tympanic membrane rupture. But regardless, let's sum it up in this way, that external ear, root of external ear that will cause otitis media is because of tympanic membrane perforation. Okay. When the tympanic membrane first gets perforated, it opens a canal. It opens the pathway to the middle ear. So this is our osteition tube, external ear, and then we have a tympanic membrane. And then we have stapes, incus, malleus, all these middle ear part, right? So if this gets perforated, the infection will enter into the middle ear and it causes an acute suppurative otitis media. Now, how does it work via the osteition tube? It is the most common route of infection that will enter into the middle ear. It is most common route. Here, the infection travels from the tube along the subepithelial peritubal lymphatics. So here in the ear, we have certain lymphatics. All right. So it travels via the epithelial peritubal lymphatics. I'll write it down here. Osteition tube. We're talking about the route of osteition tube. So the infection travels from the tube along the subepithelial peritubal lymphatics. Okay. Now, what happens? The osteition tube of infants and young children are shorter. This is very important question. The examiner will ask you, is the osteition tube of the children and adults same? No. Young children and adults will have shorter osteition tube and wider osteition tube, and that will be placed more horizontally. So thus, the account of higher incidence of infections are common in those age groups where it is children. And you will rarely hear that an adult will have acute suppurative otitis media unless and until he has a tympanic membrane perforation because of some injury. Whereas in children, it is most commonly via the osteition tube. So that's why when you feed the baby, you're asked by the doctor or the trainer to keep the baby's head elevated so that when you feed him, the milk doesn't enter into his osteition tube, because the osteition tube in children, infants are more horizontal and they are more wider and shorter. So they have more access towards the ear canal. So breast or bottle feeding in young infants in horizontal position, that will lead to the fluid entering into the middle ear. So that's why the children who are infants or who are school going with low socioeconomical status, they will have more access of the infection to the middle ear, because the osteition tube in infants and young children are shorter, wider, and horizontal. Now, in Viva, the examiner, the external, will ask you the question in this way also, that, why osteition tube is the most commonest pathway or route of acute suppurative otitis media in children. So your answer should be that it is because the osteition tube in infants and children are shorter, wider, and in horizontal position. Now, swimming and diving will also cause acute suppurative otitis media. Okay, so I'll write down some risk factors. I think I have mentioned here. Okay, I'll write it here. So risk factors can be bottle feeding. These are the risk factors due to osteition tube route. Okay, swimming, diving. Other risk factors are recurrent attacks of common cold, infections of tonsils and adenoids. Okay, so infection and tonsils of adenoids can enter into the middle ear. Past chronic rhinitis and sinusitis, nasal allergies, cleft palate, and tumors. All these are important risk factors that will cause acute suppurative otitis media. Very important are routes of infection, blood-borne, usually not seen, very uncommon. Okay, viral external ear, usually due to perforation of tympanic membrane, the infection will enter into the middle ear from the external canal and via the eustachian tube. Why? Because the eustachian tubes in infants and young children are shorter, wider, and more horizontal. Most important thing, the bacteria that causes acute suppurative otitis media is Strep pneumoniae. If you don't mention in exam this, you will lose 1 point. If you mention this, you might get 1 point. So Streptococcus pneumoniae is most important organism that causes acute suppurative otitis media, strep pneumonia. Okay. Stages of acute suppurative otitis media. Again, very important question for your final exams and also for your practical exams. So the examiner will ask you the pathology or the stage of acute suppurative otitis media. So there are 3 stages. The disease runs through these following stages to cause acute suppurative otitis media. So first thing that is that your tube gets occluded. Okay. So there will be edema of the nasopharyngeal end of the tube. Now, what does it mean by nasopharyngeal end? Let's assume this is your face. These are your ears. I know it looks funny, but then this is your nose. Okay, so eustachian tube will be like this. This part is your nasopharyngeal end. Okay, so first of all, you will have edema at the nasopharyngeal end of the eustachian tube, and this will block the tube. Now, when the tube gets blocked, there will be absorption of air and negative tympanic pressure. Now, once this tube is blocked, the pressure inside this will build up, right? There is retraction of tympanic membrane. Now, what happens is that the tympanic membrane will start retracting. So, when you do an otoscope, you will see a retracted tympanic membrane. See here. You can see very clearly the tympanic membrane is retracted, right? So this is because of the pressure that builds up inside. So from here, your tympanic membrane will start retracting. Okay. Now what happens is the symptoms comes in. Symptoms dive in. So the patient will have earache, of course, and the patient will have deafness. But these symptoms are not very, very high. Okay. There are generally no fevers in cases of tubal occlusion. The first step is tubal occlusion. This stage, the tube gets blocked at the nasopharyngeal end. Right? So the negative pressure builds in, the tympanic membrane gets retracted. The patient may or may not have earache and deafness and may or may not have fever. Now, the signs of tubal occlusion are important. So the tympanic membrane is retracted. Okay. Tuning fork test will show conductive deafness. So what does tuning fork test show conductive deafness mean? When you vibrate the tuning fork and keep it on the bone, it will show conductive deafness. Bone conduction will be better than air conduction, right? It is behind the pinna, Rennie test. So tubal occlusion. Okay, I will show you how to present this in the exam. You should write the point tubal occlusion first. And then you should mention 2 points like this. Signs, symptoms. Okay. In symptoms, you can come and you can write the patient might have deafness or earache. Usually they will not have fever. Okay. Symptoms will be retracted tympanic membrane. Sign will be retracted tympanic membrane. And which type of hearing loss will they have? When you do a tuning fork test, you will see a conductive deafness. Okay. Now, the second stage will be stage of pre-suppuration. So this is stage before the stage of pus formation. So what happens here is that if tubal occlusion becomes prolonged and if it is not treated, some children will not show the symptoms at all, and some children might show the symptoms. So children who do not show the symptom, their tubal occlusion will be prolonged. Now what happens is that the organisms will start invading the tympanic membrane, tympanic lining. And here what happens is the inflammation will start building up. And the tympanic membrane, now it becomes congested. Okay, you can see here, a tympanic membrane is becoming congested. This is a pre-suppurative stage. Okay, these are all stages of tubal occlusion. Slowly what happens is that tympanic membrane will become congested. Now the symptoms will come in where the patient will tell, I have earache. The child will tell, I have earache. They will not be able to sleep at night. It will be very severe. So in pre-suppuration stage, the patients will have symptoms and signs. Symptoms, signs. So symptoms, earache. The patient will not be able to sleep at night. No sleep. Okay. And they will have conductive deafness. They will have tinnitus. Usually the child will run high degree of fever also. So he will have fever in this stage. Now, what will happen with the sign? Now, there is tympanic membrane congestion, right? So you can write here congestion of pars tensa. You can go back to the previous class and know the anatomy of tympanic membrane. What is pars tensa? How does it get inflamed? That is very important. Congestion of pars tensa. Okay. So the blood vessels will appear at the tympanic membrane periphery. If you can see here, actually it will start beginning from here. You can see slowly, you can see the blood vessels are getting visible at the end of the tympanic membrane. This is a pre-suppurative state. So tuning fork test will again show conductive type of deafness. Remember acute suppurative otitis media, first two stages, we concluded that the patient will have conductive deafness. Signs and symptoms. Symptoms, the patient will have earache. He will not be able to sleep at night and he will have fever in second stage. First stage, usually they will not show any fever. And tympanic membrane gets congested in the second stage of acute suppurative otitis media. Now in stage of suppuration, there will be formation of pus. You can see it here. This is a suppurative state. There will be formation of pus, and this will again involve the mastoid air cells. Tympanic membrane will start to bulge out at the point of rupture. So this is where the tympanic membrane will bulge out to a point of rupture. The symptoms here again, the patient will have earache, he will have deafness, but here the deafness will be a little bit better because there is a point of perforation here. Now the pus that is built up inside, the pressure that is built up inside is slowly trying to release itself, right? So the deafness will be a little bit low, but the patient will have fever. He might also have vomiting and convulsions in very severe cases who are very, very immunologically low. The signs of these patients, what you can see in tympanic membrane, it will be red. Okay, I'll write it down here. These are signs. It will be red. It will be bulging. Right? And what else? You will see a yellow spot here where it is a point of rupture. Now, once this tympanic membrane ruptures, not tympanic membrane, this point of rupture, it bursts open and the pus gets released, we enter into the stage of resolution. But the resolution slowly begins in. So the tympanic membrane rupture will release pus and subsides the symptoms. Now, inflammatory processes will also start to resolve. The patient will not have fever. If the proper treatment is started and the infection is mild, the patient will have a good resolution. But if the patient will not have good resolution, the parents might ignore this condition and the patient might have tympanic membrane perforation. So symptoms will be evacuation of pus. So when the let's say a patient came to you with acute suppurative otitis media on resolution stage. Okay, so when you see his ear, you will see pus coming out from his ear, but he will not have earache. He will not have fever, and the child will feel better. He'll tell you, I had pain before, I was not able to sleep before, I had fever before, but now I'm fine. So this is a state of resolution already. What will be the signs? What you will see physically? Here you will see that the external auditory canal will have pus and blood, because of course there is this pus and blood coming out, right? So there will be pus, there will be blood in the external auditory canal. There will be small perforation of the tympanic membrane because the pus has ruptured the pars tensa, and this will slowly start to subside with normal Kararo and landmarks. Now, let's say the patient did not enter into the resolution stage. What will happen? This stage will lead to complication. If the organism is high and it is resistant and the patient's immunity is poor and he is not he doesn't enter into the resolution stage, this disease will spread beyond the middle ear and it will enter into the inner ear. Now, what will happen when it enters into the inner ear? You have mastoid bone behind your ear, right? So this is actually the inner part of the ear. So you will have acute mastocytitis. Okay, let me write down the complications. Examiner will ask you complications of acute suppurative otitis media, or you will have 2-mark question of write the complications of acute suppurative otitis media. Complications. Number 1, the patient will have acute mastocytitis. This is only when the patient will jump off the resolution stage, or maybe because the organisms are so severe that the patient's immunity is low and it's not able to fight with the organisms. Okay. The next, they will have inflammation of labyrinth. Okay. There's one more important thing, that the patients will have facial paralysis. Then the other complication that they have is petrositis. Petrositis. Now, petrositis is another important question. So we'll slowly slide into this topic. What is petrositis? Okay, before that, just to your knowledge, how will you treat the patient with acute suppurative otitis media? Of course, you will have to give them antibacterial therapy drugs like penicillins, erythromycins, clotrimazole, and beta-lactamase inhibitors. You have to use decongestant nasal drops. You have to give them oral nasal decongestants. You will have to give them analgesics and antibiotics because the patients will have fever. If they come in the stage of fever, you will have to do your toilet. Okay. So now, petrositis is one complication of acute suppurative otitis media. Remember, complication of acute suppurative otitis media. What you have, see, complication of acute, I have written it already, complication of acute suppurative otitis media. So here what will happen is this infection will spread from the middle ear and it will enter into your mastoid and petrous bone. Okay, petrous part of temporal bone. It will enter into the petrous part of temporal bone. Now, what will happen? It will lead to petrositis. It means inflammation of the petrous part of temporal bone. Pathology here is that it is posterior superior tract, which starts in the mastoid and runs behind or above the bony labyrinth into the petrous. So this is the pathophysiology. So what happens here is that some cells that even pass through the arc of superior semicircular canal, that will reach the apex and it will cause an petrositis. Okay. Now, anterior inferior tract, which starts at the hypotympanium near the osteition tube, runs around the cochlea to reach the petrous apex. So here it is all about the anatomy that you should know of the petrous part of the temporal bone in order to conclude what is petrositis. So pathology is clear. Now we have one syndrome that will be seen in petrocytitis, which is very important. That is Gradingo syndrome. So what actually happens in Gradingo syndrome? You have clinical features. You will have external rectus palsy. Okay. You will have deep-seated or retroorbital pain. So here you will have sixth nerve involvement. You will have fifth nerve involvement. You will have persistent ear discharge. Okay, so the examiner will ask you, what is Gradingo syndrome? Right? So you should know what is Gradingo syndrome. At least you should be able to give off the clinical features of Gradingo syndrome. So it is an external rectus, the clinical features are external rectus palsy. That is due to which cranial nerve? It is due to sixth cranial nerve. Now, deep-seated ear or retroorbital pain will also be seen in some patients. That is due to fifth nerve involvement. And there will be persistent ear discharge in some patients. Now, persistent ear discharge can be with or without pain, right? So when the ear gives off discharge, sometimes it releases the pressure. So that's why sometimes you will have pain and sometimes you will not have pain. Okay, in spite of inadequate cortical or modified radical mastectomy also points to petrocytitis. Now, fever, headache, vomiting, and sometimes neck rigidity, that is because of referred pain. So the patient will have fever, the patient will have headache, the patient will have vomiting, and sometimes they will have neck rigidity. Some patients may get facial paralysis, that is seventh cranial nerve palsy also can be involved. And recurrent vertigo can be seen in some patients. This is due to involvement of facial and statoacoustic nerve. So facial nerve can also be involved. So facial nerve is actually which nerve? It is a seventh cranial nerve. So when the seventh cranial nerve is involved, it can lead to facial paralysis. So when the patient, if they have Gradingo syndrome, which is a condition that is seen in petrocytitis. So here the clinical features, the patients might develop these conditions of facial nerve palsy. So here the nerve damage is usually seen. Okay, sixth cranial nerve can be involved, fifth cranial nerve can be involved, or seventh cranial nerve can be involved. If seventh cranial nerve is involved, it will lead to facial paralysis. Okay, now how will you diagnose the patient of petrous epicutis? You do both CT scan and MRI. Okay, you do both CT scan and MRI of the head. Okay, and CT scan of temporal bone. When you do a CT scan of head, you will see that the temporal bone will show the details of petrous epics and ear cells. Here you can see. This is the CT scan. Okay, so here in pathology, the second point that we have seen is that anterior inferior tract, which starts at hypotympanum near the Eustachian tubes, run around the cochlea to reach the petrous apex bone. So here it is somewhere related to the Eustachian tube, right? So it can involve this part. This is the apex. This is the petrous apex. Okay, so when you do a CT scan of this patient, you can see the temporal bone will show bony details of petrous apex and air cells involved, while MRI will help to differentiate it from marrow containing apex. Okay, that means it might help you to differentiate from the fluid or pus. Remember what is Gradingo syndrome. Don't forget it. At least tell the symptoms to the patient. The patient will have external rectus palsy, that is sixth cranial nerve. They will have deep-seated ear pain, or you can say retroorbital pain, that is fifth cranial nerve involvement. They can have persistent ear discharge. They might have facial nerve palsy, that is seventh nerve involvement. Okay. Now, how do you treat the patient of petrositis? You do a suitable and intravenous antibacterial therapy if it is severe, if the patient needs surgery. Treatment. You can give a cortical modified radical or radical mastoidectomy. If mastoid bone is involved, you have to remove the mastoid bone. Mastoidectomy is important. It can be radical mastoidectomy or modified radical mastoidectomy or cortical mastoidectomy. Any three. 1, 2, 3. Depending upon the situation. Okay. Now, a fistulous tract should be found out. Now, some organisms can cause fistula. Okay, they will create a tract within the cells of the body. Let's say crustacean tube is here. The infection can be, it can rupture off and it can create a small pathway like this. This is fistula opening. So you have to rule out fistula, you have to find out fistula, and then you have to curate it to form a free drainage. Okay. In most cases, what happens is that acute petrositis can now be cured with antibacterial therapy. Like I told, you can give them IV antibiotics before the surgical intervention. Now, which antibiotics you can give? You can give high doses and you can give them for 4 to 5 days of symptoms. Any antibiotic like erythromycin or penicillin, anything that comes up, you have to do a culture first. Okay. When you do culture, you will find out which bacteria is resistant to which antibiotic, and then you can give an antibacterial therapy. You should give high doses for 4 to 5 days, even after the disappearance of symptoms. Yeah, here see it's mentioned here, even after complete disappearance of the symptoms, you will have to give them antibacterial therapy. The other treatments of acute suppurative otitis media, I have mentioned it before. You have to give antibacterial therapy. I have mentioned the antibiotics. You give them decongestant nasal drops. You give them oral nasal decongestants. This is because if there is blockage of the nasopharyngeal end, right? Nasopharyngeal end. Analgesics and antipyretics for fever. You have to do ear toilet if there is discharge. Rupture of tympanic, the point of rupture. If it ruptures, the pus enters into the external auditory canal. So you will have to clear off that external auditory canal. Or else, if you let it be there, the infection will stay there and it will become more severe. Now, if there is, the pus doesn't rupture, the point of pus doesn't rupture off, you ask the patient to give it some warm local heat with a warm cloth or something. You ask them to apply heat on that part so that it ruptures. And in worst cases, what you do is you do a meningotomy. See, this is very important. Acute otitis media treatment. This is very important for FMG exam, for any international exam. This is a very important topic. Even if you write some international exams like IOPOM, MLE, any exam, this treatment is important and everyone should know. If it is an acute otitis media, you give an antibacterial therapy. This is the first stage that you do. Okay. And you should review the patient after 2 days to 3 days. If the patient responds good to the antibiotics, you should continue the same drug for 10 days, regardless the patient is having symptoms or not. Even if the symptoms subside, if the patient is responding to antibacterial therapy, you can continue that for 10 days. All right. Then the patient will have complete resolution. These are healthy patients. All right. Now let's come to this part. If the patient is having earache and fever and he is having persistent pain, which is increasing in the consistency, you have to change the antibacterial therapy to something else other than what you were giving him before. Okay. So another antibacterial therapy for 10 days, or you do a meningotomy to the patient. You have to do culture specific antimicrobial therapy for 10 days. Okay, to rule out which antibiotic is important for the patient. After this, if the patient has complete resolution, you can let him go off. But if the patient does not respond to antibiotics even after you do this, then the patient will have persistent fluid. He will come back again with earache and he will come back with fever. You have already completed 10 days with this patient. Then what you should do is you should check this patient for 12 weeks. Okay. After you check this patient for 12 weeks, if the patient has no effusion after that, it means the patient is healthy. You can conclude the treatment. Now, if the patient gets effusion even after you wait and watch for 12 weeks, you have to treat otitis media with effusion. That's the next step. Okay, so this is acute suppurative otitis media. Other one is otitis media with effusion. So here, it is very important that you should know that acute otitis media, if it becomes untreatable and the patient is not responding to antibacterial therapy, even after 12 weeks of follow-up, then you can put the patient under the diagnostic condition of acute otitis media with effusion. Okay. So acute suppurative otitis media has now become otitis media for effusion, otitis media with effusion for this patient now. Some students might have been thinking which antibacterial therapy can be used in these patients. So I will just mention few antibacterial therapy which are usually commonly used. So ampicillin, okay, amoxicillin. These are basic drugs that are used usually. And now those who are allergic to penicillins, they can go for cephalosporins. Allergic to penicillins, you can put them on cephalosporins. All right. So these are basic antibacterial therapy that you should use, but everyone should remember this table. This table is also very clearly mentioned on the textbook of Dhingra. So make sure that you look at this table and you keep just in your head, because this is very important table, not only for your academic purposes, but also for after you finish your academics. Anyone will ask you, what if acute otitis media is untreatable with antibacterial therapy? You have to review the patient for 10 weeks. And then after 10 weeks, you have to review the patient for 12 weeks. And after 12 weeks, if it doesn't conclude, then you have to treat the patient for otitis media with effusion. Okay. So now here, what is otitis media with effusion? Otitis media with effusion is known as serous otitis media. Okay, it is known as secretory otitis media. It is also known as mucoid otitis media. It is also commonly known as glue ear. Okay, glue ear. Examiner will confuse you asking, what is serous otitis media? What is secretory otitis media? What is mucoid otitis media? What is glue ear? You should know that glue ear is otitis media with effusion. If acute otitis media is not treatable with antibacterial therapy, you have to treat the patient with otitis media with effusion. So definition, this is a condition that is usually seen when there is accumulation of non-purulent effusion in the middle ear cleft. Okay, now if the pus or the effusion that gets accumulated into the middle ear cleft. Remember, middle ear cleft has 6 components. We have mentioned this in the very beginning of the class. This will lead to otitis media. This is known as otitis media with effusion. Now, the effusion can be thick. It is usually sterile. Okay, the effusion can be thick. It can be viscid. It is usually sterile. Okay, this is usually seen in children who are going to school. School-going children. Okay, pathogenesis. There are two mechanisms that are seen in otitis media with effusion. Multifunctioning of a station tube. The station tube thinks that, he is multitasking and he will do multiple functions, and then he fails to aerate the middle ear. He fails to give a normal aeration to the middle ear. And because of that failure of aeration, what will happen? The pressure will build up and the middle ear will not be able to drain the fluid. So it will stay there and it will cause glue ear. Now, the second mechanism is that there is increased secretory activity of middle ear mucosa. Now, in some patients, what will happen is that the mucosa of middle ear will abnormally secrete so much of serous components in their ear that it leads to glue ear. So here, if you do biopsies of middle ear mucosa, you will see that there is increase in mucus secreting cells. Okay, it's either the malfunctioning of the Eustachian tube. It is not able to function properly. That's why it is not able to do proper aeration of the middle ear. So the fluid gets accumulated in the middle ear cleft, or it is because of increased secretory activity of middle ear mucosa. When you do biopsies, you will see increased serous secreting cells, increased serous secreting cells. Okay. So here you see, this is otitis media with effusion. Very beautiful picture where you can see malleolus, you can see incus, you can see scapes. You can see that the eardrum is protracted. It becomes like a pocket because the fluid is accumulated inside there. Like it becomes thick amber and color fluid. I have one more image here where you can see very beautifully, you can see malleus, right? You can see incus. Here you can see scapes. You can see promontory. Okay. So this is how you see tympanic membrane in otitis media with effusion on gluea. What are the clinical features of the patients with acute otitis media or gluea? So the most important symptom is that the patient will have hearing loss. Okay, the patient will have hearing loss. This can only be the symptom that the patient might complain of. Okay, so the patient usually they will have symptoms of hearing loss, or there will be, if it is seen in children, like let's say the child is in nursery and he got otitis media with effusion. The patient actually, what happens here is that the children will be brought to the clinic to the doctor saying that my child has delayed speech. Parents will say my child has a delayed speech. This is because the child is not able to hear. He will not be able to develop speech because he will never hear proper words and he will never hear proper speech from this parent. So he will not be able to learn or grasp those words. So that's why children with otitis media effusion will have delayed speech if they are in nursery conditions. Now the hearing loss here is the presenting symptom. It is usually an insidious onset. Usually the parents will complain, my child is not listening to me. He's such a disobedient child. These children will usually be characteristically judged by the parents saying that, he never listens to me. But actually what happens is that he might be suffering from otitis media with effusion or gluea. So that's why in practical world, pediatrician always recommends that if a child does not hear you, do not judge his character saying that, he's not listening to me, maybe because he's not obedient or maybe he has some behavioral issues. You should always bring the child to do an auditory screening if he is not able to hear properly or not able to hear. The child will never complain that I'm not able to hear properly. He will just not hear. Okay, so deafness is usually insidious in this condition and may pass unnoticed by the parents. And they may accidentally discover it only when they bring the child to the clinic and the pediatrician will do an audiometric screening. That is the only condition with otitis media with effusion will be diagnosed. Okay, so hearing loss is usually insidious in otitis media with effusion, and the child will have delayed and defective speech because he's not able to hear, he's not able to grasp words from the parents. So it is an accidental finding usually. The patient might have mild earaches, but that is not the condition. He will have earache only when he have upper respiratory symptom. So when every time they have an upper respiratory tract infection, they will complain of earache, but that also will go unnoticed because it is an insidious condition, otitis media with effusion. It is called glue ear. It sounds very small, but it is actually a very, very serious condition where the child might develop delayed speech. They will have behavioral issues because they are not able to convey their messages to the people around them because they are not able to talk, they are not able to express themselves, they're not able to hear. Okay, so this is important symptoms of otitis media with effusion. See here, the child will have hearing loss. The child will have delayed and defective speech. See here, the child will only be diagnosed when there is an audiometric screening test. And the child might have mild earaches only when there is history of upper respiratory tract infection. That too, it will be mild earache. It will not be severe. When you do an otoscopic finding, just now we saw this image, right? So when you do an otoscopic finding, you will see a tympanic membrane that is dull that is opaque, and there will be loss of light reflexes. It will be dull. You can see it here. It is dull. It's dark under this. Right. Thin leash of blood vessels will be seen in most cases. Right. And you, along with the handle of malleus and the periphery of tympanic membrane, you will see congestion here. It will be a congestion maybe because of acute suppurative otitis media. Now, tympanic membrane may vary a degree of retraction. It can be severe retraction and it can be sometimes mild retraction. In some cases, you will see fluid levels and air bubbles. You will also be able to see air. Here you can see fluid level. Here, you can see fluid levels. In some cases, you will see air bubbles in the tympanic membrane. And when you try to mobilize the tympanic membrane, it will be restricted because it's tensed. Okay. So this is acute suppurative otitis media. Otoscopic findings are here. Okay, tympanic membrane is often dull. It is often opaque. It becomes yellow, gray, or bluish in color. There will be thin leash of blood vessels that may be seen along the handle of malleus. Tympanic membrane may show degree of retraction. It can vary. Fluid levels and air bubbles are seen in most cases, and mobility of tympanic membrane is restricted. Okay, how do you treat these patients with otitis media? So there are two ways where you can treat. First is medical and the other one is surgical condition. Okay, so medically what you do is first you put the patient on decongestants in the form of nasal drops or in the form of sprays or in the form of systemic decongestants. It's up to you. You put him on decongestants so that you relieve edema of the eustachian tube. You also put him on anti-allergic medications, antihistamine drugs, or sometimes they are combination of steroids can be used. Okay. And then you put them on antibiotics, maybe acute to treat some, if it is followed by acute suppurative otitis media, antibiotics will help. And you do a middle ear aeration. Now, how do you do middle ear aeration? Here, the patient should be repeatedly undergoing a manole, sometimes known as polarization. I will write it down here. It's politerization. So what actually happens here is that you catheterize the eustachian tube. Now, when you catheterize the eustachian tube, you create a vent to the middle ear and you promote the drainage of the fluid, right? You can also give, when you do catheterization to the patient, you can give them chewing gums and you can encourage them to keep their jaw movement in and out. You can give them chewing gums and toffees so that, this moves. So when you are moving your jaw, this we had in a previous class, when you move your jaw, there is constriction of the muscles of the eustachian tube that will promote the drainage of the fluid, right? So these are medical treatments that you do. Okay, conservative management we say, and then there is surgical management. Surgical management, you do laryngotomy and aspiration of the fluid. Now, how do you do this? You make an incision in the tympanic membrane and the fluid is aspirated with the help of suction. Okay. Now, when you suck it out, you see a thick mucus. Okay. If there is thick mucus, then you will need to instill saline or mucolytic agent, usually known as chymotrypsin solution, that will liquefy the mucus before it is aspirated. So you do an incision and you make a tympanic membrane fluid to aspirate. Now, what if this mucus is thick? You give them chymotrypsin. Okay. Chymotrypsin. This will liquefy the mucus and it will help to aspirate it easily. Sometimes there are need of 2 incisions in the tympanic membrane. If there are need of 2 incisions, then you make 1 incision and anterior inferior part. Sometimes 1 incision will not be helping to drain the fluid. So you will have to make 1 incision at the anterior inferior part and 1 incision at the anterior superior part. So 1 incision is made at the upper part and the other incision is made at the lower part. Okay, if you make this type of incisions, I'll draw and show you if this is a tympanic membrane, let's say. right? So you make one incision here, you make one incision here. Okay. You make anterior superior and anterior inferior incision. And when you make these incisions, you can aspirate a thick glue-like secretions. Okay. Uh, and then we have gaumet insertion. Now, if meningotomy and aspiration, you do a meningotomy and aspiration, you let the fluid come out. Now, some doctors, they will prefer to put a grommet insertion. They insert a grommet. This will help to keep the vent open, and it will provide a continued aeration in the middle ear. If it is left in that place for months or weeks, it will spontaneously come out by itself. You do not have to reoperate the patient to remove the garment. Okay, grommets are usually spontaneously extruded. So you can combine these both surgical procedures of meningotomy and surgical aspiration. It's just like incision and drainage. And then you can insert a grommet. When you insert a grommet, you provide a continued aeration to the middle ear. And after a few weeks, months, what will happen is that it will spontaneously come off. Now, other procedures is tympanotomy or cortical mastectomy. It is usually required when the fluid is thick and loculated and it is not coming off. Okay, so when there is cholesterol granuloma, otitis media with effusion, if they have cholesterol granuloma, then you can do a tympanotomy or cortical mastectomy. I'll write it down here. Okay, if the fluid is thick and loculated, you can do tympanotomy or cortical mastectomy. Now, if surgical treatment or causative factor, if conditions like adenoidectomy, tonsillectomy, or you wash out the maxillary intra, you can do all these procedures to sometimes see you will have to treat the cause, not the symptoms. So it can be that otitis media with effusion is because of adenoids or tonsillitis or adenitis. Okay, so if the adenoids are swollen or if there is tonsillitis, the patient might develop otitis media with effusion. So always treat the cause and the causative factors. If it is adenoids, do adenoidectomy. If it is tonsillitis, do tonsillectomy. If it is maxillary intra, then you have to wash out maxillary intra. Okay, so remember, there are two ways where you can treat otitis media with effusion. I'm sorry. Two ways to treat otitis media with effusion. It is medical and surgical procedure, conservative management and surgical management of acute otitis media with effusion. Now, let's say the patient is having recurrent otitis media. So here you should know the management of children with recurrent otitis media. But let's just talk about it before we dive into the management here. So infants and children between 6 months to 6 years will usually have recurrent otitis media. They will have acute otitis media. So when there is recurrent acute otitis media, it is known as recurrent acute otitis media. Okay. These episodes are called, when do you say acute otitis media is recurrent? When do you say that? If the patient is having more than 5 episodes in a year, it is known as recurrent acute otitis media. More than 5 episodes per year. Okay, it is known as recurrent otitis media. Usually what happens is that the patients first, they will have viral infection, either upper respiratory tract infection, okay, or some other infection like sinusitis, rhinosinusitis, some infection will be there, viral infection. And then the child will recover from that acute upper respiratory tract infection. And then what will happen is that he will have recurrent middle infections that will sometimes be superimposed as middle ear effusion. Okay, so sometimes the underlying cause is sinusitis, okay, hypertrophy of the adenoids, or infected tonsils, or maybe allergy, or maybe just the child is immunologically immune deficient. Okay, feeding the babies in supine position is very important If you do not feed the baby in supine position, you will have recurrent or acute otitis media. So if a mother comes to you whose child is on bottle feeder and she comes to you recurrently 5 times, 4 times to the clinic saying my child is having ear infection, my child is having ear infection, you have to recommend her to put the baby in supine position without using a prop up. Okay, because this will cause the milk to enter into the middle ear directly. That can lead to middle ear infection. If the mothers are, usually this is seen in gravid mothers who are first time, these who are first mothers, they will repeatedly do this mistake. And these children will come up with recurrent acute otitis media. So if it is more than 5 episodes per year, you can conclude that the child is having recurrent otitis media. Okay, now how do you manage this patient? So management is finding the cause and eliminating it. This is what you can say. If it is hypertrophy of adenoids, if it's allergy, or if it is a mother itself who's not able to feed her child in the proper position, she might the one who will be, who might have been inducing a recurrent otitis media in the child. All right. And then you give the child antimicrobial prophylactic treatment. That is amoxicillin. Okay. Most commonly used is amoxicillin. Usually it is a very good antimicrobial drug that will prevent the reoccurrence of the child. The other thing you can do is maringotomy. See, here I have mentioned here amoxicillin. It is used, but they prevent only 1 to 2 bouts of otitis media in a year. Okay, and they have a disadvantage of creating antimicrobial resistance. Of course, this is the most common problem of any antibiotic or any antimicrobial drug, that it will cause resistance, or they might even cause an hypersensitivity reaction. Okay. Now, the other thing is that maringotomy and insertion of tympanostomy tube. Now, if the child is having 4 bouts of acute otitis media in 6 months, okay, or let's say if the child is having 6 bouts in 1 year, then in that case, you will have to do tympanostomy. Okay. Here, maringotomy and insertion of tympanostomy tube. If the child is having 4 bouts of acute otitis media in 6 months, or if he is having 6 bouts in 1 year, normally it is more than 5 episodes in 1 year, right? It is called as recurrent acute otitis media. Then you have to insert a tympanostomy. And then you have to do adenoidectomy or tonsillectomy if that is the condition. And you have to manage the patient with inhalation of any milk product or food allergy. So this is about otitis media, recurrent acute otitis media. Okay. We have one more topic, that is aero-otitis media. Remember that we have covered that in the previous class. You can go in that previous class and you can see that topic very clearly. Now coming to mastoiditis. Mastoid bone is present behind your ear. Okay, and the definition of mastoiditis is that it is the infection that spreads from the mucosa lining of mastoid air cells that involves the bony walls of mastoid air cell system. That is the definition of mastoiditis. Okay, so it is when the infection spreads from the mucosa and the lining of mastoid air cells and it involves the bony walls of mastoid air cell system. That is when you have mastoiditis. So symptoms are very important. Mastoiditis, they are similar to that of acute suppurative otitis media. Now, what are the symptoms of acute suppurative otitis media? Let's go back to the first page. Acute suppurative otitis media. Here we have the symptoms of acute suppurative otitis media. The patient will have 3 routes of infection. Okay, these are the risk factors. These are the stages that you should know. It will have the same complication. It will have the same picture of acute otitis media. The patient will complain of earache. The patient will complain of deafness, and the patient will complain of fever. Okay. But before that, I think I forgot to cover up acute necrotizing otitis media. So let's cover up that and then we'll go for mastoiditis. So acute necrotizing otitis media. It is another important question. I think I skipped this page. So it is a variety of acute suppurative otitis media. It is just like acute suppurative otitis media only. So what happens here is that it is seen in children suffering from measles or from scarlet fever or from influenza. Okay, so it is usually seen in children who are suffering from any immune problem like measles or scarlet fever or influenza. And the causative organism is here is beta hemolytic streptococcus organism. Very important. They will ask you in the exam, not theory. If not in theory, they will ask you in practical, beta hemolytic streptococcal infection. Okay. So this is a rapid destruction of the whole tympanic membrane. Now, in this case, what will happen is the whole tympanic membrane will be destroyed. And this will create a chain to enter into the mastoid air cells. Okay. So here, see, mastoid air cells will be involved. From here, you will have mastoiditis. Okay. So acute necrotizing otitis media can lead to mastoiditis. So there is otorrhea. The patient will have profuse otorrhea. In cases, what will happen is healing followed by fibrosis. The patient will have fibrosis. And they might also have secondary acquired cholesteatoma. Secondary acquired cholesteatoma. Okay, fibrosis is common. If it is self-resolving, there will be fibrosis. Now, how do you treat the patient? You give them antibacterial therapy for at least 7 to 10 days, even if the response is seen clearly. Now, remember in any question in ENT or any disease in ENT, you should continue the treatment if the patient is responding well. This is the key. You cannot say, okay, the child is responding well, so I will stop the treatment. No, the child is responding well means it is the drug that is acting on the child and you have to continue it. Okay, so antibacterial theory is continued for 7 to 10 days, even if the response is seen. And if it is not seen, then you have to do cortical mastoidectomy if the medical treatment fails, okay, to control the complications of acute mastoiditis. So the complication of acute mastoiditis is what? It is acute necrotizing otitis media. Now, let's go back to the point of mastoiditis, where we came from. Okay, we have it here. Mastoiditis. Mastoiditis is a condition when the infection spreads from the mucosa, right? That lines the mastoid air cells and involves the bony walls of mastoid air cell system. The symptoms here they are similar of acute suppurative otitis media. The patient will have pain behind the ear. So your mastoid bone is behind the ear. So the patient will have pain behind the ear. The pain is acute. The pain is seen in acute otitis media, but it subsides with perforation or treatment with antibiotics. Remember the stages that we have with acute suppurative otitis media. So if there is perforation, it is self-resolving. Now, if there is ear discharge, the patient will have fever. The patient will have ear discharge. So in mastoiditis, the discharge becomes profuse. It increases in purulence. And any persistent discharge beyond the 3 weeks in cases of acute otitis media, we say that it is mastoiditis. So in acute otitis media, you have to follow up the patient for 12 weeks. Right. You give them antibacterial therapy and you follow up for 12 weeks. If that antibacterial therapy does not work out, you conclude that you have to treat the patient for otitis media with effusion, that is clear. Now, if the patient is having swelling behind the ear, okay, and if you see the signs and symptoms of mastoiditis, the mastoid, it gets inflamed within 3 weeks of acute suppurative pain, before 12 weeks, in between the follow-up. If you see that the mastoid bone is getting inflamed, then you have to rule out that the patient is having mastoiditis. I hope I'm very clear about this. You have to follow up the patient with acute suppurative otitis media for 12 weeks if antibacterial therapy is not working. If it is not working, you have to treat the patient with otitis media with effusion. Now, within 3 weeks, you see that the patient is having inflammation behind the ear. That is mastoiditis. Then you have to conclude that the patient is having mastoiditis and you have to treat for mastoiditis. You have to stop continuation of ruling out otitis media with effusion and you have to stop here and you have to treat the patient with mastoiditis. Now, let's see what are the signs that you see in the patient to say, okay, he has mastoiditis. Mastoid tenderness will be seen. Mastoid bone will be tenderness. It is a very, very important sign. So let's say your patient is having acute suppurative otitis media, okay, and you're following up from 12 weeks. You're putting him on antibacterial therapy. And within 3 weeks, the patient is saying, I have pain behind my ear. Then you have to rule out that the patient might have mastoiditis. The tenderness is by pressure over the middle part of the mastoid process and its tip and the posterior root of zygoma. In short, the mastoid bone will be painful. The patient will have ear discharge. Now, what will be the nature of ear discharge? The nature of the ear discharge can be mucopurulent or purulent. Okay. And the patient will have often a pulsatile lighthouse effect. Now, the perforation here will be from the center of pars tensa. Remember that. Perforation from the central part of pars tensa. Also, there will be sagging of posterior superior meatal wall. Because the mastoid bone is involved, it might cause sagging of the posterior superior meatal wall. Now, since it is having signs and symptoms similar to acute suppurative otitis media, there might be perforation of tympanic membrane to release that pressure. Usually a small perforation is seen in pars tensa. Perforation may sometimes appear like a nipple-like protrusion. Just remember that stages of acute suppurative otitis media. Okay, you have a point of rupture. It's saying the same point. Okay, the patient will have swelling over mastoid, of course, and there will be hearing loss. Which type of hearing loss? The patient will have conductive type of hearing loss. So when you beat the tuning fork and you put it on the mastoid bone, it is known as Rennie test, right? So you will hear bone conduction hearing loss. So general findings are the patient will appear ill, they will be appearing toxic, they will have low grade fever, and in children, fever with high raise, their pulse rate will be very high. So it is actually a very painful condition. Now, where do you do tympanoplasty? Tympanoplasty is a surgical procedure. But what are the conditions where you do a tympanoplastic procedure? So tympanoplasty is actually done to eradicate the diseases of the middle ear. You can see it is usually done to eradicate a disease in the middle ear or to reconstruct the hearing mechanism of a patient. It can be combined with mastoidectomy. If it is required, the patient is having mastoiditis, then it can be combined with mastoidectomy if the disease demands. Okay, and type of middle ear reconstruction depends upon the damage done. If it is a larger tympanic perforation, then you have to do a larger middle ear reconstruction. If it is a mild thing, then you can do a small tympanoplasty. Now, the repair is usually limited to tympanic membrane. So they can be either meringoplasty or it can be ossiculoplasty. Okay, so if there is a reconstruction of ossicular chains, we say it as an ossiculoplasty. And if it is a reconstruction of tympanic membrane, you see meringoplasty. Or if there is both, then you say tympanoplasty. Now, remember that you read in thoroughly by heart these definitions because the examiner can ask you these questions. Okay, so remember that tympanoplasty is when there is reconstruction of tympanic membrane and ossicular chains. And if there is only reconstruction of tympanic membrane, then it is meringoplasty. And if it is reconstruction of ossicular chains, then it is ossiculoplasty. I hope that is very clear. Now, types. There are four types of tympanoplasty. No, actually 5 types of tympanoplasty. Type 1, 2, 3, 4. Okay. So this is actually done to repair the perforation of the tympanic membrane usually. So the defect is perforation of tympanic membrane, which is required with a graft. So here you have to use a graft. It is called as meringoplasty because here you will only repair the tympanic membrane, right? So this is known as meringoplasty. When there is only tympanic membrane, it is meringoplasty. Now type 2 is defect of the defect is the perforation of tympanic membrane and there is erosion of malleus. Okay, if there is erosion of malleus, the graft is placed on incus or the remnant of malleus. We have a diagram here. I'll show you. Here. See. type 1 graft is placed as malleus. So this is actually the type 1 which they are saying here. Type 2 graft is placed at incus. Okay, so defect is perforation of tympanic membrane, and here the graft is placed at incus or malleus. If there is leftover malleus, you can place it on leftover malleus also. Now, type 3 is graft placed on stapes head. Okay, this surgical procedure is known as meringostepidopexy. Okay, type 3 is known as meringostepidopexy. Okay, meringostepidopexy. Pexy, not plexy. Pexy. Okay. So type 3 is where malleus and incus both are absent. Okay. Here you cannot see malleus, you cannot see incus in this diagram, right? So the graft is placed at stapes. Right? So this condition is known as meringostepidopexy. Now, if there is only tympanic membrane graft, that is known as meringoplasty. Right? Now, type 2 is where there is perforation of tympanic membrane and you place the graft on incus or leftover malleus if there are any. Or if the type 3 is known as meringostepidopexy, where the malleus and incus both are absent and you will have to place the graft at the stape's head. Okay. Now, type 4 is only the foot place of stapes are left. You see here the pink colored one, this one. Right? And the graft is placed between the oval and the round window. So if you can see it in the diagram here, this is your oval window and this is your round window. So the graft is placed between the oval and the round window. So this is type 4. And in type 5, what happens is stape foot plate is fixed, but round window is functioning. Now, what will you do in such cases? Another window is created on horizontal semicircular canal. Here you can see. You create another window and it is covered with the graft. This is also known as fenestration operation. Fenestration done in horizontal. See, it is written here, fenestration done in horizontal semicircular canal. So this is known as fenestration operation. So I'll repeat again one more time. So type 1 surgical procedure is defect in the tympanic membrane itself, and that is known as meringoplasty. Now, type 2 is defect in the perforation of tympanic membrane and the malleus is eroded. So the graft is placed at incus or leftover malleus. Okay. Now, type 3 is where malleus and incus both are absent and the graft is placed at the head of stapes. This is known as meringostepidopexy. Type 4 is where the graft is placed between oval and round window. You can see this diagram. And type 5 is known as fenestration surgery, where you create an extra window over the horizontal semicircular canal and you cover it with graft. That is known as fenestration operation. So these are the pictures of grommet. We all know we have covered the topic of grommet in the previous videos. You can go back to that videos and you can see what is grommet. This is a 2-mark question. Okay. So I just made sure I present a picture here so that you know what is a grommet. It is usually placed in conditions with glue here. Okay. You can see here. This is how you place a grommet. And this will spontaneously extrude from the ear after a few weeks to days. So this is how a grommet looks like. All right. So this is the class that we had today. Meringotomy. This is a surgical procedure. See here, you do an incision or either in the anterior superior part or inferior part. And you place a grommet here. This is a very beautiful diagram where you can see this is how you place a grommet. And you can see a yellow color fluid effusion coming out of the tympanic membrane, fluid draining into the ear canal. Okay, so this is how you do meningotomy. So where do you use grommet? You use grommet in meningotomy procedures, right? To drain off the fluid from the ear, usually done in cases of glue ear. That is otitis media with effusion. Thanks for watching. Keep following us on our social media platforms. Hope you like the class. Thank you so much.